Well, good morning, everyone. It's the top of the hour, so we're going to go ahead and get started. I know that a lot of people are still joining us, so we'll give everybody just a minute to settle in here. But welcome to our webinar on diagnostic excellence today. We are so happy that you were able to carve out a little bit of time to join us today for this. And happy Patient Safety Awareness Week. So as everyone's getting settled, we would invite everyone into our virtual greeting by chatting in your name, your organization, and then we would love to hear what all of your organizations are doing to celebrate Patient Safety Awareness Week. So go ahead and put that into the chat. And we welcome you to continue entering thoughts or questions into the chat as we go along today. So nobody involved in this discussion today has anything to disclose. For our objectives today, we plan to discuss some of our key advancements and challenges in the field of diagnostic excellence. We're also hoping to touch on some evidence-based strategies and best practices. And then finally, we're going to leave you with some tools and resources that will help you advance some of your local diagnostic excellence strategies back at your local organizations. We are offering continuing education credits today for all attendees. So following our call today, we will be sending out an email that will include our copy of the recording from today's call, the slides, as well as instructions on how to claim those continuing education credits. We would like to just take a moment to thank our sponsors, the Gordon and Betty Moore Foundation, for the wonderful work that they do, as well as for their partnership with us and for the support of this Diagnostic Excellence webinar today. So this call is hosted by the IHI Leadership Alliance. The Leadership Alliance is really a dynamic group of organizations and leaders. I'll just go back a slide here, sorry. So organizations and leaders who work so well together to innovate, collaborate, and advance quality efforts within healthcare, so all with the shared goal of delivering on the full promise of the Triple Aim. So we're very honored to work with this group. So this is a list of our current members. So we currently have almost 60 organizations across the United States that work together. So it's truly an honor to work with this amazing group and be part of all the impactful work that they're doing together to advance healthcare. As part of the IHI Learning or Leadership Alliance, we offer a variety of programming throughout the year. One of those programs is a local learning series. We have different topics that we cover throughout the year. This particular local learning series is focused on patient safety. So today's call is the third call in a 4-part series that is designed to look at patient safety and really evaluate how we can advance patient safety and get back to the basics of patient safety, while also thinking about some new and innovative strategies that align with the changing healthcare environment that we're all living in. And today's call is also opened up to the broader IHI audience. So we welcome all of our existing Leadership Alliance colleagues, and we also are extending a very warm welcome to the broader IHI audience that is joining us today. We're very happy that you're able to join us. So with that, I'm going to introduce our panelists today. It's my pleasure to introduce Karen Cosby. Karen Cosby is going to be moderating our discussion today. She is an emergency medicine physician at Cook County Hospital. She's also an associate professor at Rush Medical College. She is the medical officer at the Center for Quality Improvement and Patient Safety at ARC. And she was very recently a program director at the Gordon and Betty Moore Foundation, working with their diagnostic excellence and quality programs. We also have Colonel Stephen Coffey joining us. Colonel Stephen Coffey is co-founder for Patients for Patient Safety US. He also sits on multiple patient safety and family advisory councils, including MedStar Health, Society to Improve Diagnostics in Medicine, Centric C3, and Hope for Henry Foundation. He's an adjunct professor within the MedStar Institute for Quality and Safety Academy for Emerging Leaders in Patient Safety, and he is also the Chief of Staff for the National Security Agency. Jean-Luc Tilly is a program manager for the healthcare ratings at the Leapfrog Group. At Leapfrog, Jean-Luc convenes their patient and family caregivers expert panel. He's also responsible for programs to assess hospitals for diagnostic excellence and programs that recognize hospitals that lead the nation in managing care of people living with diabetes. And then finally, we have Dr. Gary Weissman. Dr. Gary Weissman is a critical care physician at the University of Pennsylvania. He's assistant professor of pulmonary and critical care medicine and informatics at the University of Pennsylvania, Perelman School of Medicine. And Dr. Weissman's research focuses on the development of effective, equitable, and transparent clinical informatics tools that improve care processes and patient outcomes. Some of that includes artificial intelligence, which we're very excited to hear about today. So we want to extend a warm welcome to our panelists. Thank you so much for joining us, and we're very excited to have you joining and sharing your expertise with us today. So as we hand it over, we want to invite all of our attendees to place any questions that you have for the panelists into the Q&A. Because we have a large group today, you're welcome to put any thoughts or interact with each other within the chat, but we just want to make sure that your questions don't get lost within the chat. So please utilize that Q&A function to send questions directly to our panelists. And with that, I'm going to hand it over to Karen to moderate our discussion.
Thank you, Amy, and good day, everyone. I want to take a moment to also acknowledge the Gordon and Betty Moore Foundation and IHI for their strategic relationship and partnership in helping to move diagnostic excellence forward. And I'm grateful for all of you attending today, along with our experts. I'd like to ground our discussion in just some basic facts. We now know that there are significant estimates for diagnostic error in healthcare in general. We know that they occur in up to 5% of ambulatory visits, and that they're identified as potentially contributing factors of potentially preventable harm in up to 10% of inpatient autopsies. We know the claims data show that diagnostic errors are a leading cause of claims, and the claims that are associated with the greatest potential harm, even death, and the greatest payouts. This problem is pervasive throughout healthcare. In fact, it's estimated that each of us will likely experience one or more diagnostic errors in our lifetime, either in ourselves or in those we love. So we often speak about diagnostic error, but I'd like to frame today's discussion around something more positive, around the concept of diagnostic excellence. That is, diagnosis as accurate, timely, efficient, safe, patient-centric, and equitable. Well, sometimes this message seems depressing and the numbers are staggering. In fact, there's a lot of work going on in the field, and our experts are here today to really relate what's going on that can improve our systems of care and improve patient experience and outcome. We know that by your presence today, that you probably are really interested in knowing what you and your organizations can do. So let's move forward with our discussion today, looking forward to real solutions and strategies all of you can take home with you. So I'll begin our discussion today with Colonel Coffey. Now, Colonel, as a distinguished military officer, it's not easily apparent how you would become an expert in diagnostic quality or a founder for patient safety and a patient advocate. Tell us, why is this important to you?
Well, thank you so much for the opportunity to be here and for all of you joining on this Patient Safety Awareness Week. You know, I think there are a lot of correlations between what I do as a senior military officer and what we do in healthcare, because we have two high reliability organizations. And I'll tell you what really started me in this space was my son. And so I generally start by saying a quote by Charles Dickens, and he said that it was the best of times, it was the worst of times. It was the age of wisdom, it was the age of foolishness. And those words never rang more true than with the birth of my son, Stephen Coffey II. And you see a picture of this young man. With his life, my life absolutely changed forever. So Stephen was born September 28th, 2012, and I was excited. I was going to have a son that was going to carry on my good name. And what I found is that his birth changed me because he was taken away by the nurses and the staff, and they ran normal newborn screening tests. And when they came back, they told me that he had this high bilirubin, low glucose. It was a little bit jaundiced, but they assured me that he would be okay. And I had true faith and trust in them. And what I found out later is that he had a rare metabolic condition called galactosemia. And his galactosemia was misdiagnosed, and there was a delay in the diagnosis as well in the military health system. Now, they have absolutely circled the wagons, if you will, and look for ways to fix that. So this is no slight on the military health system. But it was one of those things that really opened my eyes to a lot of the gaps and seams that are present, pardon me, that are present in healthcare. And so when I look back at his experience, and I think about when he was born, and there was a provider who called me, and I had them on speakerphone. And I'm thinking the speakerphone would allow me to make sure that there's nothing that's lost in translation between the provider and my family, my wife and I. There was a barrier that was created there. There's a barrier because it was a speakerphone. There was a barrier because that provider had a very pronounced accent. There was a barrier because that provider told me that I needed to go to a larger institution, a larger hospital, and tell them about a complex medical condition. Now, for those of you who may be unfamiliar or have forgotten, galactosemia is a metabolic condition whereby his body cannot break down the simple sugar galactose that's found in human and animal milk. So simply put, his mother's milk was damaging his liver. So there's a tertiary effect that we currently deal with, you know, we caused harm rather to our son, even though we didn't do it intentionally. But when I looked at his delay in diagnosis there, and the misdiagnosis occurred, it was around November the 28th of 2012. And my son, Stephen, his name is Deuce. So Deuce, I take him to the hospital because my wife calls me and says there's a lump on his leg. And I go in and I'm dressed in very comfortable clothes. I do not look like I look right now, but I go in very comfortable clothes. And I tell this provider, there's a lump on my son's leg. I'm concerned. And the provider all but dismisses me. They told me that that lump was nothing more than fatty tissue or swollen lymph node. And I was dismissed. Now, what I found later is that therein was bias. I didn't look like I do now. He didn't know that I was a senior military officer. I was labeled as this overreactive parent. I was labeled as my wife was labeled as this overprotective mom, and our concerns were not heard. And so when you think about what thrust me into this space, those two things propelled me to get here. The capstone of that is what you see here in the picture. After we had gone to the hospital in November and gotten dismissed, we'd gone back the very next day. And at that time, the provider did know I was a senior officer. It was very clear that I looked different. I sounded different during that engagement. And we were sent up to a large hospital in the Mid-Atlantic area, the DC area. And I will never forget this day. There was a resident presenting my son to a senior attending, and they said, "This is Stephen, our 2-month-old from an outside hospital. He has fulminant liver failure, secondary to galactosemia." And 5 days later, Stephen had a transplant at the tender age of 8 weeks old, youngest in the country to have a transplant, certainly in 2012 and for a number of years afterwards. And so when I look at the care he received, when I look at the diagnostic process and where I could have engaged as a patient, I see lots of gaps and seams. I see lots of places that I could have engaged that potentially would have had a very different outcome for him. And so I'll give you the quick update. I mean, Stephen, he is an 11-year-old kid now. He's an author of a children's book, Baby Stephen's Gift of Life. He is doing well, but he always refocuses me every time I see him, every time I see his scar, on the why I do this. The last thing I'll say, you talk about the parallel between military service and healthcare. I often say that when your avocation, what you love to do, and your vocation, what you are paid to do, when those things intersect, you find purpose, you find happiness, you find the reason, you find your why. And so my why was birthed from him. And again, it's just working with health providers to ultimately make care more inclusive of patients and our patient voice and safer. That's why. And there's some of the parallels.
Wow, thanks, Colonel Coffey. That your experience is really moving and compelling. Let me focus us on what health providers can do. Dr. Weissman, you take care of patients in intensive care units, and you bring to that expertise as well in clinical decision support and informatics, and dare I say, artificial intelligence. Now, I know many people are excited, but simultaneously terrified of the potential of AI in general, but also particularly in healthcare. Tell us about the work you're doing, what you think about the potential of AI in health, and particularly in diagnosis, both the potential and the risks.
Thanks, Dr. Cosby, for the question, and thanks for the opportunity to be here today. Really excited to speak with you, and I really appreciate Colonel Coffey's sharing his story in the beginning to really ground this in the care of patients, which it's easy to get lost in talking about AI in sort of a lofty sort of way. But really the reason we're talking about it is because we do want to improve care for patients and make their processes and outcomes better. So thank you for that. Right now, I think we're in a really exciting time, and there's tremendous potential for AI to improve decision-making in clinical care, to alleviate burnout by taking up repetitive tasks. Burnout is something that threatens a lot of clinicians, our workforce right now, to really help us make less biased decisions, because AI can prompt us to reason through our decisions rather than relying on heuristics or biases. And it offers potential to help us learn from all of the data streams that are generated in modern healthcare systems. I prefaced all that by saying there's tremendous potential. And what I mean by that is right now, the scientific evidence that AI can actually or does actually do all those things is still quite small. And so that means that all of the hype, the enthusiasm, the market incentives for AI systems have to be balanced against a focus on patients, which means focusing on effectiveness, safety, and equity of using these systems in clinical practice. And right now, we're in this in-between space where the potential is very, very high, but the evidence is still very low. And so there's an important role for scientists and researchers to try and help bridge that gap so that when we are moving forward with using AI systems, that we're doing it with an emphasis on effectiveness, safety, and equity. With respect to diagnostic excellence in particular, we know that, as you pointed out in the beginning, Dr. Cosby, a lot of errors are due to breakdowns in history taking and physical exam. A lot of clinicians, especially in the primary care space, are operating under cognitive strain and information overload. Just like in Dr. Coffey's story, a lot of clinicians rely on heuristics and make biased decisions based on a patient or family member's sex, race, age, or other characteristics. And there's growing evidence too that clinicians don't enough incorporate family members and patients into the diagnostic process, who often have rich information that we need to arrive at the right diagnosis. So I'm optimistic that AI systems offer a means to alleviate a lot of these obstacles, and I see tremendous potential. At the same time, as I said, I think we need evidence. And so we need a strong regulatory framework to incentivize and require that evidence. We need the right stakeholders at the table to oversee these efforts. And that includes not just clinicians, but patients, family members, data scientists, ethicists, just to name a few. And so in this vein, in the research space, I think it's an exciting time to be working. My lab is focused on producing that evidence for AI diagnostic support systems, both in the outpatient primary care setting and also in the inpatient side in the ICU. And if there's time, I'm happy to talk about that more later. But I do think there's tremendous potential. We just don't really have the evidence yet of safety, effectiveness, and equity to move forward with deploying these systems in a widespread way. And so I think one of the challenges that a lot of hospitals and clinics and health systems face is, how can we build a process or a governance committee or an oversight mechanism to make sure that the tools we're investing in and using in our practices are effective, safe, and equitable?
Wow, thanks. I know that we could spend quite a long time exploring all those things that you brought up. But to advance the general conversation, I'm going to pivot to Jean-Luc Tilley and then come back and summarize things in a moment. So while your work is high-tech and aspirational, I think, Jean-Luc, your work seems very pragmatic, on the ground, immediate. So I know that you've worked with NQF on developing quality measures, and now you pivoted to work with the Leapfrog Group to help in their diagnostic excellence program for surveys of hospitals on things that can be done now in the moment in terms of processes and policies. Can you tell us how you made that pivot and tell us a little bit about the Leapfrog Group program?
Yeah, thanks, Karen. And thanks very much for having me here today. So Leapfrog is a patient safety watchdog group. Most hospitals in the country report data to us on a set of a few dozen quality measures. So that spans concepts from, like what we think of as patient rights, around billing ethics, for example, or whether a hospital sues patients or unpaid hospital bills, or how well they're handling their informed consent process. Some more, kind of critical patient safety issues appropriate for this week. So implementation of medication reconciliation, adequate staffing of ICUs, that kind of thing. And then more sort of outcome-oriented measures that reflect patient preference and an intersection of what we know about patient safety, so like the rate of C-sections or other things in maternity care. So Leapfrog actually got started on diagnosis a little bit before I joined, just a couple years after the National Academy's report on diagnosis came out in 2015. In 2017, Leapfrog worked with some researchers at Hopkins to survey hospital leaders. So the same folks reporting to Leapfrog survey to find out what was behind the slow progress on diagnosis nationally. And at that time in 2017, they found that actually hospital leaders totally recognized the gap in diagnosis, but were really craving specific guidance on what to do next and what kinds of quality measures they would need to help them make a business case, to help them choose where to focus their effort. So when I joined Leapfrog in 2020, we had an opportunity to get some funding from the Gordon Betty Moore Foundation to set some of those quality measures in the structure and process area. So we convened first a panel of clinical experts and patients and payers to help us identify actually 29 different practices that we recommend hospitals to adopt to reduce diagnostic errors. And I'll just say, I think of that as sort of like the menu at the Cheesecake Factory. So there's a lot of different things to choose from there. But we don't expect you to do it all at once. Just a little bit of a caution whenever I talk about the 29 practices. And actually, starting next month in April, we're going to start collecting data nationally on how far hospitals are in implementing some of those key practices, the few where we think quality reporting can accelerate implementation right away. And then, after a sort of learning year and this upcoming year, we're hoping to start actually publicly reporting individual hospitals on their progress in implementing some of those key practices. So our hope is that, just like in so many other areas, transparency around performance there at the hospital level will incentivize a transformation to make them safer places for patients and better at diagnosing.
Thanks, Jean-Luc. So if I think about this, you all are kind of coming at this problem from a variety of perspectives. So for Colonel Coffey, it seems to me that we're talking a lot about culture change and patient engagement. We need ways for patients to somehow engage in their healthcare and know how to be effective communicators with clinicians. And we need clinicians to be able to have the workflow and the culture of listening to patients. And from Dr. Weissman, we know there are tools on the horizon, and maybe some even available now. So we need a framework for safe implementation, and we need to know what are the good tools to support diagnostic excellence. And from Jean-Luc, there are some very practical ways that systems can begin to build safer systems for better diagnosis today. So if I ask you all just in a quick run through, what can people who are attending this program today begin to do in each of the areas that would make a difference today? And then where do you see yourself maybe in 5 years? So they have a vision of where to go with this, to go home energized to start today, but develop something perhaps more than a vision for just Patient Safety Awareness Week, but something over time with long range goals. So I'll mix it up, and maybe I'll start with Dr. Weissman.
Oh, great. Thanks for the question. Yeah, I think in the short term, to really make sure that your hospital or clinic or health system is using AI safely, the best thing to do right now is ask the leader of your clinic or service line or department or wherever you work, say, what's our plan for investing in, deploying, and monitoring AI systems here. And I think that's important because if there's not a plan, then almost certainly someone is going to say, well, I saw this great system, it was pitched to me, we invested in it, now we're using it. But if without a plan, we're not going to know if it's safe, effective, equitable, and there's not going to be a return on investment to the clinic. So I think starting that conversation locally to know what's our governance plan here, how are we going to oversee this? That's really the short-term goal. And then the 5-year plan, like you were saying, Dr. Cosby, is to really grow that system locally. It's going to have to be sophisticated because there are going to be a lot of stakeholders at the table. There's a lot of infrastructure that's needed to do that work. And then hopefully over time, we'll advocate at the city level, the state level, the federal level for policies that really help with that oversight, help with regulation to ensure the safety and effectiveness of these kind of systems.
Can I add to that question? If you are currently using any machine learning, NLP, or AI in your practice, or if not, where you would suggest people begin, or where you would recommend your system begin?
That's a great question. In our health system, we have had several clinical prediction models deployed over the years. Many of them have been de-implemented over time after it turned out that maybe they weren't helping as much as we thought. I think there's a lot of enthusiasm now around large language models like ChatGPT and things like that in particular. Again, those are very hard systems to regulate and to use for clinical decision support, especially for diagnosis. I think the lower hanging fruit is to use those kind of systems really for workflow things. And as long as in our health system, for example, we have an instance of ChatGPT that is behind the firewall, it's HIPAA secure, it's protected, data never leave the system. And so that's an opportunity to say, can we use this to help draft letters or draft messages, not to write them and send them, but to draft them to alleviate some burden on clinicians who would then review and edit and ensure accuracy and integrity. So I think those kinds of use cases are the low-hanging fruit where there may be shorter-term benefit to using those kinds of tools.
Thanks. That seems easier than just generally aiming for something abstract.
Yes, very easy, very concrete.
Yeah. Colonel Coffey, how can we help do better by patients to empower them and to interact in a more healthy way with them?
So I think the first thing we have to do is value the patient voice and really not just see the patients as consumers of healthcare, but really as partners in healthcare. And I think that's really a shift that's starting to occur now, right? So we start to talk about when you have open notes and patients are able to see what's going on with their healthcare. And now if a provider takes that patient who is now armed with some data and engages that patient, and you mentioned earlier, patients have this entire story. I look at my son, I say, I could see him like an entire movie. I see start to finish. I can tell you what his AST, ALT, GGT Prograph numbers were and how they're impacted from December the 5th when he had a transplant up until Monday when I left. And so I'm a data node that could be utilized to give you a better picture of what healthcare looks like for my son. But that requires really respecting and valuing the patient voice. And I think that the thing, and I'll tell you this, I'll parallel this to the military, change is not something that we like to do, right? But I think that when we find that not changing is scarier than changing, then we're forced to change and we start to do that. And we're at an inflection point in my mind in healthcare where we're starting to see that not changing healthcare, not trying to be inclusive of patients, and I want to say not addressing our biases, right? And understand that biases, whether they're unconscious biases, they're not just relegated to race and gender, but really opening that aperture and expressing and understanding our biases for our LGBTQ plus community, for insurance, inequalities, for all of these other things, these social determinants of health, these other factors that play into how we practice and administer medicine. We have to recognize those things. So you talk about how do we do it? I think it's one, valuing patients. And I'm going to add on to one of the things you said, like, where do you see yourself in 5 years and how do we get there? There is a move afoot. And I talked about this tectonic shift that's going on, I believe, in medicine. There's a move afoot now to have this National Patient Safety Board. There's a bill that is bipartisan bill with one congressman from Texas and one from California to really advance this notion of having this federal agency similar to the NTSB that would provide some oversight. And so I really believe that, in my heart of hearts, that 5 years from now, we will have that thing in place and we will start to continue to just move this ball further down the field to make care rather, more inclusive and certainly keep it patient centered.
Excellent. Jean-Luc, maybe could you help us also think about among the Leapfrog program, what some of the very practical ideas are that are suggested in the work that's been going on to identify practices that are more likely to support optimal diagnosis?
Yeah, absolutely. There are a few, but one I think that's really important that intersects nicely with Colonel Carthy's concept around valuing the patient is also valuing the patient's voice as a leader in the hospital system. And so by that I mean the PFAC, but the Patient Family and Caregiver Advisory Council. Over the COVID public health emergency, a lot of PFACs stopped meeting, or for one reason or another were disbanded. I think now is actually a great opportunity to reconvene those PFACs and refocus them around diagnosis. So the Society to Improve Diagnosis in Medicine worked with Leapfrog to put out a toolkit for hospital leaders. Really, all you have to do as a leader at the hospital is hand over that toolkit to your PFAC and ask them to take a look, to start meeting, to start thinking about practices. Number one, they'll educate themselves on what's going on in diagnosis, but then two, they'll be able to propose concrete strategies specifically narrowly tailored to the local circumstances of the hospital to advance diagnostic excellence. So that's one really important one, I think. Another is convening a multidisciplinary team at the hospital that's going to focus on diagnostic excellence. And that team could choose a lot of different paths, but I think one important one really is to conduct analyses of diagnostic errors. So of course, to make that possible in the first place, you need some kind of a reporting pathway, some kind of structure at the hospital to encourage clinicians to feel safe and feel comfortable reporting potential diagnostic errors so that those can be analyzed. And then after root cause analysis has been conducted, that the findings from that analysis can be distributed throughout the hospital, in trainings and things like that, so that we can prevent those kinds of errors from happening again. But one thing too that I think maybe gets overlooked a little bit is just the potential for a leader at the hospital to set the tone by formally committing to making diagnostic excellence a priority. So, it sounds trite maybe, but it's free to do, right? It can be done in a moment. Ideally some thought would go into it and all that. But I mean, really it's setting that cultural shift around recognizing that diagnosis is a priority for the hospital, committing to one kind of specific formal action, any one of those 29 practices, and then starting to kick off that transformation, I think can be really important.
Thank you so much. As I think about attendees, I even think about my own personal experience in healthcare. People can really care a lot about this topic, that sometimes they feel very alone in it and somewhat siloed. I wonder if each of you could comment on where you go for help, partnership, or where do you go for specific resources, or if you want to promote a particular resource that you think people might benefit from. I think people would like to go away and feel there's a broader community and there are specific tools and resources available to them. How about I begin with Colonel Coffey?
Yeah, so I think that there's a couple ways. So when I look for the normal support, that high touch type of support, it really does go back to connecting with people. So I have learned that the more I engage with healthcare providers, the more educated I am about healthcare. That's point one. The more I engage with healthcare providers, the more I'm able to help them see my perspective as a patient and as a partner in healthcare. That's point number two. Where I go for some of the things that are like the high tech piece. So I do go a lot to the ARC website and really utilize the resources that are out there to, you know, one, keep me abreast of things that are changing in medicine. And so utilizing those resources, you know, medical journals, all those types of things that really keep us on the cutting edge. The last thing I do is I engage with everyday people, because what I've learned that medicine is, and it always has been and will forever be, a people business. And so every single person that I meet in the hospital or I meet around the country, someone, they know someone or they have been affected by diagnostic error, by medical harm. And so sharing those stories gives me an opportunity to learn more about the scope of diagnostic excellence as they're marching toward that. And so I think it goes back to where I get sources of help would be the hospital and the staff. It's from websites and organizations that really continue to keep me in a learning mode, and then it's back to people.
Jean-Luc, you have any ideas?
Well, I'd certainly echo taking a look at ARC's website and just, you know, reviewing some of the latest publication. I mean, just last month, issue brief 16 came out. That's a nice kind of overview of the state of the science in diagnosis. And I would actually, maybe they'll not appreciate this, but you know, I would reach out to the authors. You know, I work with a few of them in my own area, but you know, the researchers there are really supportive, really helpful, really eager to spread, you know, the knowledge that they have in their area to break down those silos. I think that can be incredibly valuable. The experience that I've had at Leapfrog here, convening our panel on diagnosis, has been really illuminating. I think, you know, the reason we arrived at those 29 is because there's just such a diversity of approaches there, and they're all really valuable. They're evidence-based, and it can be a really phenomenal kind of one-on-one conversation to have with a person who's published a report that you find interesting. So I'd suggest reaching out to them directly. But then too, you know, the Society to Improve Diagnosis in Medicine, you know, has an annual conference, has a leadership consortium. I mean, there are all kinds of different opportunities there to even, you know, just as an individual clinician to spend some time on their website, join, go to the conference and learn about what's happening there. You know, I'm not a clinician, but I find that information really invaluable. I feel like I learned so much. So those two I would spend some time on. And then, you know, if you've got some time, obviously Leapfrog's, you know, we've got our report, we've got our survey. I'm very available over email. I'd love to hear from any individual clinicians on, you know, any kind of homegrown effort you've got there, so we can spread the word.
And Dr. Weissman, you have any thoughts to add to that?
I would say from the AI angle in this, you know, AI is still new. And so most places haven't really figured out yet how to bring all the right people together in the room at the same time. And so I find a lot of my work is often like a social organizer. I hear from clinical committees like a primary care service line lead or a critical care consortium patient safety lead who's concerned about diagnostic error in their particular domain. But to then build and develop AI tools and then also test them, we need to have the data scientist, the lawyer, the researcher, sometimes the sociologist, the ethicist, and other folks in the room at the same time to really do that kind of work well. And so a lot of my work is finding those right people who are excited about this and then trying to bring them together in conversation. And that's, I think, is what it is going to enable us to do the clinical trials, to really build the evidence base to see if AI systems are safe, effective, and equitable for improving diagnosis. And we have a number of planned trials going forward. And so I'd say if anybody wants to reach out to partner on these kind of efforts or just to talk about them, I'd love to hear from you. Every hospital and health system is doing this a little bit differently, and there's no one single recipe. But building those connections across disciplines, across roles that weren't traditionally there or supported in a university setting or in a hospital setting. I think that kind of work is really important.
Well, those are all excellent ideas. I think I would just add to that what ARC is doing. If you go to the ARC website, there are a number of resources and tools that are available for this. We'll share some links at the end that you can take home with you today. In some of the issues that have come up, I know that there are other federal organizations working actively. The President's Commission has also authorized work to determine where AI guardrails should be put in place and how it should be regulated. And there's a tremendous amount of background work. I know that there are other trials ongoing funded by the Moore Foundation that are active and should be revealing of important insights in the coming years. And I think I would also mention that there's a Center of Diagnostic Excellence just recently launched at University of California, San Francisco, that's just beginning in its work, but it's going to be a center of digital innovation, and they should be adding a lot of content to this area. So I welcome you to try all those things. And I want to thank our panelists for their very thoughtful comments. And we have suggested we would open the session up now for just a few questions. So I'm looking over your questions, and some of them are quite expansive and perhaps not all within the domain of the expertise that we have immediately available. But I will take one about AI bias as well as bias in general in healthcare, because it's not just in AI, it's actually in our practice, to see if any of you would like to comment on that. And since it seems perhaps easiest to start with Dr. Weissman, I'll begin with you and then I'll allow anyone else to comment if they like.
Sure. Yeah, thanks for the question. This is really important. And as you said, Dr. Cosby, that although it's an AI problem, it's also a much larger problem beyond AI. So it begins and ends outside of that. I mentioned in my introductory remarks that AI systems can offer an opportunity to prompt clinicians and patients and family members to be more deliberate in their reasoning, to review data more methodically, to engage the diagnostic process in a more systematic way and potentially reduce errors. So I'm optimistic on that end. At the same time, AI systems learn the patterns in the data that we give them. So a really common example is that women experiencing myocardial infarctions are much less likely to be diagnosed initially compared to men, because of the way historically we've talked about and taught medical students and other clinicians about the symptoms for that kind of thing. So if we trained an AI system to detect those based on existing data, it's likely that the AI system would also misdiagnose women having myocardial infarctions, which would then further compound delays in diagnosis. So that's just one example, and there are many, many other examples by race, ethnicity, language, age, many other categories that Colonel Coffey mentioned before, sexual orientation. And so it's important to have the guardrails, to have the oversight, to have the interrogation process built into the development, testing, and deployment of these AI systems. And if we don't have that kind of framework, then I think we're not going to improve inequities. We're likely to worsen them, or at best just continue propagating them into our healthcare. So I agree there's a tremendous risk there, and that's why this has to be done carefully with the right stakeholders at the table and with a lot of transparent data and oversight.
Dr. Colonel Coffey, I know you like to.
Ditto. Go ahead. No, I'm going to say one thing because ditto. I think that a lot of times we think that AI is going to solve the ills of the world, but you have to remember that you have to make sure we've got inclusive data. So AI is amazing. We are doing a lot of work with that in the Department of Defense, and certainly as it's emerging really around the world. I mean, it has blown up when you think about what ChatGPT is doing and where we've gone from a year ago to now. But I think you go back to that one point that we've said of making sure that we have inclusive data. And so that means we have to engage people. right? If we're going to use data sets that are already pre-existing, they're already filled with bias. And that was one of the comments that was in that question. There are biases that are already baked into the data we have. And so we have to not only look at AI as a potential solution, but we also have to look at it a little critically and say, well, how do we make sure that this accounts for bias? How do we make sure this data set is inclusive and have a little bit of a question mark behind it? Because then when we do that, we're thinking at what I tell the troops, you're thinking at that tertiary and quadrennial level, not just, oh, here's a data set and here's what it's going to produce, but you're thinking about what is it missing and how can we use that as a tool to help us get better.
Well, as long as we're on the idea of bias, I think there's also a more general theme that's coming up in the chat about disparities in care. How do we address the reality that not everyone has equal access to equal quality? I will just briefly mention that ARC is very interested in this area, and we're sponsoring a forum with the National Academies to discuss it. There's also been recent work in progress through Academy Health, if you want to check the Academy Health site, that's actually looked across the NAM framework and identified areas where we think disparities impact quality, and expanded that framework to look at pre-hospital and care in the community, something that's sometimes neglected, is not obvious to those who work within healthcare systems. I don't know if any of you would add any ideas about how you think we could approach the problem of inequities and disparities in quality of care.
So let me jump in really quick because I think there's a reframing of this as an ecosystem. And so here's where I bring that in. And so right now we have medical care. Everyone understands medical care. If I go to the hospital and say that my left arm hurts, you're going to fix my left arm. But when you prescribe me medicine, are you also thinking about those other factors that continue outside of the four walls of the hospital? And so what I mean by that is, like, I have an Apple iPod or AirPod, rather. AirPods in my ear today, iPad now, iPhone. It's a healthcare ecosystem. It is an Apple rather ecosystem. And we have to look at healthcare in that same ecosystem type manner. So for example, when a patient comes in and we're prescribing them medicine, there's an assumption that they have access to clean drinking water. Flint, Michigan, Jackson, Mississippi, those are recent places. You know, this is not decades ago. Flint, Michigan, Jackson, Mississippi still have drinking water issues. We're assuming that the person has access to reliable transportation. So those factors also contribute to those determinants of health, those social determinants of health. Those factors also contribute to bias. And so when we start to reframe medical care as a healthcare ecosystem, we can start to then identify biases or those blind spots. I'll give you one quick model. There are two American psychologists that made up Johari's window. And I love that model because it has 4 quadrants in it. So there's one quadrant that says there's stuff you know about yourself and they know about you. That's called shared knowledge. There's stuff that you know about yourself that others don't know. That's called your secrets, or really what they call is the facade. There's stuff that neither of you know about each other, and that's the unknown. But the sweet spot, I think, is what is the stuff that others know that you don't know. Now, if I was in the DoD, I'd say that's gossip, but and I'm sure there's no gossip in any other organization. But that really is the blind spot. And so when you think about disparities, we think about that's a blind spot. And the only way we can address blind spots is to engage where that blind spot is. So if we have a blind spot with different genders and ethnicities and sexual orientations, we need to recognize the blind spot and then intentionally go and engage there. And I think that's where we look at this cultural change, is that we have to be very deliberate in our approach and very intentional in our engagements and recognize those blind spots.
Well, I think our time is almost up for this portion of the program, and there's no way to do it really justice, except I hope that if nothing else, we've stimulated your thinking and we've given you some starting points. I will acknowledge in the chat, there's wonderful things where people are discussing what they're doing for Patient Safety Awareness Week. We congratulate you and thank you for that. I'll mention that there's some really big themes going on in just so you go away thinking about them, about how can you exchange data and make information across systems? How can we be be sure that we foster diagnostic stewardship so that we don't end up doing excessive diagnosis? How can we be revealing of diagnostic problems without landing ourselves in legal risk of malpractice claims and worries about finances? Obviously, the issue is quite complex, but I'll leave us with the idea that there are obviously some very smart and talented people putting their efforts to this problem. There are solutions and strategies going forward, and we really hope you leave today with a sense of hope and some beginning ideas about what you can take home to do today and how you can imagine a better future. So I think our time is up. Thank you to our expert panelists for their insights and all your work in the area. And I'll turn it back to Amy for closing.
Thank you, Karen. And thank you so much for our panelists today. This was a fantastic discussion, your wealth of knowledge and resources here. So we really appreciate your time. And thank you again to the Gordon and Betty Moore Foundation for their support of this program today and making this possible. And thank you to all of you who have joined us today. I know that there are still some questions and comments popping up in the chats and within the Q&A. I apologize that we're not able to get to every one of them, but maybe our panelists can continue to respond to those within the chat as we're wrapping up here. We do have a couple of slides here from our panelists that outline some of our resources from both AHRQ as well as from Leapfrog. And just as a reminder, we will be sending out a copy of all of these slides as well as the recording and the instructions for claiming continuing education credits after this call. So looking ahead at next steps in our Alliance calendar. So we have IHI Patient Safety Congress coming up here in the very near future of May in Orlando, Florida. So we would love to see several of you there in person. And here's a QR code if you would like more information on the programming or to register. And then we're also looking ahead to December already. So we have the IHI Forum coming up in Orlando, Florida, December 8th through the 11th. There's a QR code that will take you to the early information on the forum. The call for proposals is now open. So abstracts are due on April 30th, 2024. So we would encourage any of you that have projects going on or we would love to highlight the great work that you're doing within your organizations. So please consider submitting an abstract to share that work at our IHI Forum in December. For those of you within the Leadership Alliance, we have several upcoming programs. So we have an Alliance Roundtable coming up on Thursday, March 28th, where we're going to be discussing whether it's possible to save money or not in healthcare. So Dr. Don Berwick is going to be facilitating that call with another fantastic panel with Kathy Howell, Prandeepa Parmanduri, and Chris Van Gordon. And then next month, April 11th, it's going to be our last call in our local learning series on patient safety. So we're going to be exploring the safety operating systems and really trying to analyze whether the safety operating systems we have in place today align with the goals and the priorities that we're setting for our organizations for tomorrow. So as you can see, we have a great panel lined up, all from within the Leadership Alliance, and look forward to that conversation. So as we're wrapping up our patient safety learning series, we will be moving into our next local learning series on social drivers of health. So that will start up in May and will take us through the summer. So we have 3 dates scheduled for that. And then we also look forward to seeing many of you at our in-person spring meeting in Washington, D.C. So again, thank you so much for taking time out of your very busy schedules today to join us. Thank you for all the work that you're doing with diagnostic excellence and patient safety. And please enjoy the rest of your Patient Safety Awareness Week activities within your organization and have a great rest of the day.